Welcome to ASRM Today, a podcast that takes a deeper dive into the current topics in reproductive medicine.
I'm Jeffrey Hayes. Today on the show, we're discussing fibroids with Dr. Linnea Goodman. Dr. Goodman is an OBGYN who is subspecialty certified in reproductive endocrinology and infertility. She specializes in fertility, reproductive surgery, polycystic ovarian syndrome, and fertility preservation. She is passionate about providing individualized, patient-centered care. Dr. Goodman, welcome to ASRM Today.
Thanks so much for having me.
How did you get started in this? What got you interested?
Yeah, so when I started out my career, my degree was in biomedical engineering. And so I had an interest in kind of the way the body worked and new technology and kind of figuring out the inner mechanics of things. And so I actually went into medicine thinking I was going to do orthopedic surgery because I had so much experience in kind of the mechanics of artificial joints and ligaments. And that's what my research was in college. So I entered medical school and I found that I loved every single piece of the rotations. So I would do peds and I wanted to be a pediatrician. I would do neurology and I want to be a neurologist. And so as I went through these, there were kind of some major milestones that I really connected with. And that was procedure-based things. So I loved surgery. And then I loved being able to see the start of a problem and then the end of a problem and fix it. And so I realized that taking care of diabetes was not for me because that was a long-standing issue that I'd never be able to start and finish. So I originally thought that I would be a GYN oncologist. I had some amazing mentors. And so entered residency thinking I was going to do oncology and focus primarily on surgery. And then quickly realized in residency that I erred more towards the happy side of medicine. The cancer patients was really difficult for me and the dying at the end. And if you did your job really great, you never saw the person again. And that was not super satisfying to me either. And so I was looking for a place that I could do a lot of surgery, but still have, kind of the more, the happier sides of medicine. And certainly infertility is not always happy, but definitely we do have a beginning and an end most of the time that is happy. But I knew that I loved surgery and that wasn't something I wanted to give up. And so I focused that as an area of interest and went to Cleveland Clinic for fellowship. That is really strong in reproductive surgery and did a ton there and really, had my skills honed there under some amazing mentors. And so then I've kind of come out and used that as a sounding board and a jumping board for lots of different things. And so I kind of specialized in bringing people back to their normal anatomy. I don't want to alter their body to something that it's not, but I'd like to bring it back to a place where, Mother Nature can do her best work and get pregnant as naturally as possible. And so that's kind of where surgery became a focus for me.
And that's so wonderful too, because it sounds like you wanted to have sustained connection with patients, to really develop that, almost like someone who goes to a GP, once a year and it's just like, oh, hey, it's you, and you sort of develop that. And I'm sure that there are other people in the field who completely understand and empathize with what you're saying and how you're feeling. It's interesting you make that statement at the end about bringing the body back, right, to the best state it can be to reproduce, to have children. The focus of our talk today is fibroids. And I had no personal knowledge or connection with it until my wife, and she went through that. And then I have sisters and they went through that. What kind of populations, are most likely to have fibroids?
Yeah, fibroids are super common. It's not something that we think about until it affects your life. But 50% of women by the age of 50 have some experience with fibroids. And many of them don't ever know it, or they're found incidentally. They're found at a time of C-section, or they're having a CT scan for some other reason for an appendicitis and they see a fibroid, or we're doing an ultrasound for a kidney stone and they see a fibroid. So many of them are asymptomatic and don't cause any problems. We see a fair amount of them in the fertility world because we're looking for them. And so I think that's when we kind of pick up on them more acutely. There's a whole a whole subset of women that are asymptomatic, and it doesn't matter. There's a subset of women that are symptomatic, either with heavy bleeding or pain or pressure. And then there is the infertile population that comes in, and there's a high prevalence of fibroids in the infertile population. And that's kind of the population that we're focused on.
So, but would you say on average, it's most women are targeted in that 45, 55 range, or is it 50? It's necessarily just 50 and above is average.
Actually, most postmenopausal women, the fibroids will shrink. And so fibroids are generally not a huge issue postmenopausal. And so I would say the majority of time that they are symptomatic and difficult would be somewhere between 30 and 50.
What's some of the current thinking on whether removal of fibroids is necessary during infertility care? Like is it a certain type of fibroids, or methods of removal? Yeah,
this is one of the most controversial topics in our field, mainly because taking out fibroids is not a small deal. So there are three major types of fibroids, and actually, in the categorization, there are now a number of them, starting from stage type 0 all the way up to type 8. But the kind of major categories that I think of are ones that are in the uterus, which are submucosal, whether they're in the wall of the uterus, and that would be intramural, or whether they're on the outside of the uterus, and that's subserosal. So in general, we know that fibroids in the uterus are detrimental to fertility and miscarriage and reproductive outcomes. Fibroids outside the uterus that are subserosal are not generally have an impact on fertility. And then the ones in the wall of the uterus are the ones that are the most difficult to treat and the most controversial. So in terms of removal, if they're the majority of them inside of the uterus, so a type 0 fibroid would be completely inside the uterus, those ones are able to be removed hysteroscopically. And that's a simpler procedure. It's outpatient, low risk, and has a large impact on success rates. Once you get intramural, so this is when the fibroids are within the wall of the uterus. Now, this is when this becomes a little bit more nuanced. So at this point, we're going to be looking at the size of the fibroid and the location of the fibroid and the extent at which it would take to remove this fibroid. So, a general rule of thumb, 5 centimeters is a term that's thrown around a lot as kind of your threshold to remove it. There's many reproductive endocrinologists that would say that if you are asymptomatic and there's no impact on the cavity, then they would keep it in place, upwards of 7-8 centimeters. The reason being that taking out a 5 or 6 centimeter fibroid that's in the wall is a surgery that's going to require, abdominal incision. So either doing it laparoscopically, robotically, or open, and can create scar tissue and then potentially set up this woman for a C-section in the future. And so it's not a small deal to take out this fibroid. We also don't have great data that it helps when you take this out. However, the downside of keeping this in is that a lot of women present with miscarriage. And so if you have an 8 or 9 week miscarriage and you have a 5 centimeter fibroid, what you don't want to do is have this happen again and feel like the fibroid was contributing to this.
Is it when you said it, depending upon the size or the removal of the fibroid, is there a division between, say, like a regular, a non-specialist doctor can do it, or like, is that the degrees you're talking about?
Yeah, it's a great point, and one that I think is overlooked a lot of times. So the thing about fibroid surgery is that the more you do, the better you are at them. And the more often that you do them, the more your skills stay honed. And so I find it with my own skills that when, fresh out of training and in my first job where I was operating all the time, I am much more aggressive in the size of fibroids I take out, as well as you can do it faster with lower blood loss. And you could potentially do, a more skilled surgery and, do it minimally invasive opposed to, an open surgery. And so are all OBGYNs trained to do myomectomies? Yes, for the most part. Do I think patients are better off in the hands of people who are high volume surgeons? I do. This has been proven in terms of cancer surgeries. It's been proven in terms of, these complicated endometriosis surgeries. that the more you do, the better you are. And there's certainly people that have, specialized in this very small niche of, fertility patients who need fibroid surgery.
Well, I appreciate your time today and your absolute expertise. And I have just one more question for you today. Is there anything that you're seeing, or that you're researching, or maybe you're working with others that has you excited about things coming in the field to help in these areas?
Yeah. So fibroids have been around forever. We've known about them for centuries at this point. And we are finding more and more minimally invasive ways to combat these. So there's now ultrasound guided radiation, and then there's the excessive procedure. There's all sorts of procedures that are aimed at dealing with the inner workings of the fibroids and combating them from the inside, versus when you do surgery, you're basically just, ripping out that tissue and then allowing that tissue to heal and fill that void. The things that are exciting are thinking about how the tissue forms and how we can combat that tissue from the inside out. And so, providing some sort of sound waves, providing some sort of, intrafibroid injection that would combat the tissue and cause it to necrose. So I think there's a whole lot of things, especially now that it's becoming more and more prevalent in fertility care, that you want to keep it minimally invasive and not do these giant surgeries. I think that we're going to find more and more ways to combat this without major surgery.
Well, that is good news. As always, my guest today has been Dr. Linnea Goodman. We've been talking about fibroids. Thank you so much for being able to come on the show, and I'd love to have you on again sometime.
It's been a pleasure to be here. Thanks so much.
You can subscribe and rate the show on Apple Podcasts, Google, Stitcher, and good Lord knows there's like 30 of these things now that you can subscribe to. So if you type in our name, you can find us, or you can go from our show page, and we're happy to guide you there. If you have questions about this show, you can email me, asrm@asrm.org. I'm Jeffrey Hayes, and this is ASRM Today.
This concludes this episode of ASRM Today. For show notes, author information, and discussions, go to asrmtoday.org. This material is copyrighted by the American Society for Reproductive Medicine and may not be reproduced or used without express consent from ASRM. ASRM Today series podcasts are supported in part by the ASRM Corporate Member Council.
The information and opinions expressed in this podcast do not necessarily reflect those of ASRM and its affiliates. These are provided as a source of general information and are not a substitute for consultation with a physician.